بنبلش اليوم السيشن تبعنا. It's my honor to welcome our dear colleague, Dr. Hassan Shahata. He's a dear friend to all the three societies, where his work and passion had made a remarkable impact in our specialty. Dr. Shahata has contributed greatly in research in miscarriage, intrahepatic cholestasis of pregnancy, obesity, and diabetes. And I am sure he will continue to inspire us with his dedication and leadership. Please join me in giving him a great warm welcome as he shares his talk with us on innovation to address maternal obesity. Dr. Hassan.
شكرا عبير، شكرا ماهر. Thank you, Dr. Falah. It's a great pleasure again. And actually, this is really an important topic because in the UK, in my clinic now, I think we can officially say that more than 50% of our patients that we see are either overweight or obese. More than 50%. And that's a problem I think we all face around the world. So when Mahir, Abir, and the scientific committee asked me to speak about obesity, I think initially we were thinking about bariatric surgery, but I said to them, actually, let's look at what else can we do, the innovations that we can come up, because in pregnancy, there's a lot of things I believe we can do. And I think that's important because you can see there, one of the most important parts of my job is the one in the middle there, where I'm the clinical director for the maternal medicine network in my region. So in the UK, we now have created several maternal medicine networks where we try to aspire for our patients to have equal care wherever they are. And that's really, really quite important to achieve that. And my job is to look after the 8 hospitals and make sure a woman, wherever she is geographically, she can access the best care according to her condition. So what is the problem at hand? I think we can all agree that this is a global prevalence of increased significantly. And the WHO has described this as a global epidemic. We know that overweight and obesity has nearly tripled over the last few decades. And maternal obesity in particular has become a major health issue for us to deal with. Now, some of you are aware of the Embrace report, where we in the UK look at all maternal and babies' death and try to assess and try to learn from the findings to help us how we improve our care. And I think this is what has happened over the last few years. It has been important to have the Embrace report. But what is really important from this slide is that the Embrace report has clearly shown that high maternal BMI is associated with maternal morbidity and maternal death, associated with stillbirth, is associated with pregnancy complications such as postpartum hemorrhage, infection, cesarean sections, you name it, it is all comes back to a high BMI. So what are the maternal risks? We start from the first trimester. We've heard today from Professor Tom Bourne about the link of miscarriages, preeclampsia, pregnancy-induced hypertension, gestational diabetes, thromboembolic disease, which is still the #1 cause of direct maternal death in the UK. And of course, some of you who do ultrasound scans, that sometimes can be very difficult to assess the baby's size, and looking at the fetal medicine colleagues agree with that. Then you come into labor. Some of you will come and encounter women with a BMI of 60 and 70 and 80. How do you deliver that patient? And all the complications that are associated with it, anesthetic-wise, dystocia-wise, and also the surgical difficulties and the risk of intrapartum and postpartum hemorrhage. And of course, these women are also at increased risk of infection, increased risk of detachment from the baby, lack of breastfeeding, and thromboembolic disease. So definitely something needs to be done. And I don't know how many of you will have an open and transparent discussion with your patient in the first trimester when she comes with a high BMI. Do you tell her all the possible complications? Do you tell her about all the risks that are going to happen? Because some of us, we don't, because people shy away from having these difficult discussions. These women with a very high BMI are not for the faint-hearted. They should not be looked after in small units. They need to be looked after in well-equipped teaching hospital or military hospital setups. What about the baby? Higher risk of congenital abnormalities, stillbirth is as twice. But what I am really interested in this childhood and adult obesity. So for me, I know some colleagues that say, well, this is a government community issue that they have reached here with a BMI of 60. What am I going to do in pregnancy? I only have few months to deal with it. But there is a link that these women produce big babies who eventually have big complications of cardiovascular metabolic disorders. And can we break that link? So what are the challenges that we're currently facing? There are very few pharmacological options that we can use during pregnancy that are considered safe in pregnancy. What about lifestyle modifications? Is exercise, eating well, stopping carbohydrates, improve outcome? I remember Professor Kypros Nicolaides said to me, Hassan, there is a reason some people are obese. It's all about food habits. So if you try to explain and change their food habits suddenly, it's not an easy thing to do suddenly. And there is also socioeconomic factors. In the UK, it is much cheaper to buy a fast meal like McDonald's or KFC or Burger King. And it's very expensive to buy vegetables and fruits. So we also need to think about that because there is also a social divide. So in my practice, I work in 2 hospitals. St. Helier, which is in the middle of a very large estate where we have a lot of low socioeconomic class patients who, unfortunately, they normally eat this kind of fast foods. While on the other hand, on Epsom, we have a very affluent area of Surrey where you meet the bank managers, the barristers, the doctors, and the lawyers. But they have different issues, normally not related to weight, but more related to old age and pregnancy. And then there is a stigma. I remember when I wanted to first set up an obesity clinic in our practice 20 years ago, the biggest question for me was what to call the clinic because of the stigma associated with it. So we started asking our patients. And some of them were very light-hearted. And I remember one said, why don't you call it the Fat Birds Clinic? And some said, well, we could just call it as it is, Obesity Clinic. At the end, we decided to call it Cedar Clinic, so a name of a tree. But everybody knew what they were going and coming for. So what are the current management strategies that we have? Dietary and lifestyle. So we all tell our patients, stop carbohydrates, exercise, and try to improve your physical activity. Behavioral counseling is important, and that's really, really crucial. And then consider maybe pharmacological agents, such as metformin in patients in particular with gestational diabetes and polycystic ovaries. And then, of course, you need to look after these patients as a team. So I have a team I work with, including Professor Steve Heyer, who's an endocrinologist. I have also dietitians, and we have also the fetal medicine team because we arrange for them a special pathway of multiple scans. But let's look at what the evidence tells us. All these studies, millions and millions of pounds, have shown no benefit. So even if you exercise, even if you eat well, even if you do all these lifestyle changes, it has not led to a better outcome on babies' weights, cesarean sections, infection, you name it, did not show really much appreciated outcomes, which is very disappointing. But one of the areas that we all kind of seem to be concentrating on nowadays is what we call gestational weight gain. So the idea here that if you have two women with the same BMI, through the course of the pregnancy, if one has less weight gain, then the outcomes are better. So there is some suggestions from some studies that less gestational weight gain will improve outcome. So if you look at it from the behavioral changes and the lifestyle changes and the exercise changes, there is no direct impact. But if you come through the weight gain, there is some benefit. So that's really, if you like, what I call a beginning of a green shoot, that if we affect weight gain during pregnancy, then we may have better outcomes. So, drug interventions. Metformin is a very interesting drug. So metformin was first mentioned by my kind of ancestors, the pharaohs, where they have actually written those days that this leaf, when you boil it and drink it, it reduces polydipsia and polyuria. So that's an early sign that it works for diabetes. The Greeks as well. But really, it became of an importance as a drug when Professor Jean Stern from Paris coined it as glucophage, which is the glucose eater, and that's in Latin. There is a considerable safety of metformin in pregnancy. It does cross the placenta, but there is a possibility that metformin may have a wide-ranging benefit effect. And therefore, could it be used as a drug for obesity? Let's look at what obesity does, and let's what metformin does. So we know in obesity there's an increase in insulin resistance. Metformin, everybody knows, it improves insulin resistance. But there are other benefits from metformin. Hyperglycemia, it reduces hepatic gluconeogenesis. It's a very strong anti-inflammatory drug. It also causes weight reduction and reduces fasting insulin, improves lipid profile, improves endothelial function, as well as an antioxidant effect. So it looks like a marriage made in heaven. And that's why, no wonder, metformin is currently being investigated as an important drug of rejuvenation to keep people young. So some of us have thought about whether metformin will help when it comes to obesity. So this trial done by Chizitek and Caroline et al. Was published in the Lancet back in 2015. And what they looked at is that all women with a BMI of 30 or above, given metformin up to 2.5 grams from 12 weeks onwards, and looked at the outcome. And the main outcome was reducing the baby's weight. And the secondary outcomes would be things like diabetes, just hypertension, etc. And what they have found that in this particular study, there was no difference. So very disappointing. At the same time, we were doing a trial called the MOP trial, and that's together with my colleague, Professor Kypros Nikolaidis, but we had a different approach. I had a different approach by actually saying that we should really target patients with a BMI of 35 or above rather than 30, because if you decide to take it from 30 or above, you will find that the majority of your patients will be in that category, because there's a lot of them. While the BMI of 35 or above, a smaller number of patients, it will take you longer to do the study, but then you are targeting patients, in my opinion, with high inflammation, high oxidation, high endothelial dysfunction, and high insulin resistance. And therefore, this will allow the metformin to show its benefit. The other change we've done, that we went up to 3 grams a day, which is above what the BNF would recommend. And I was comfortable with that because we know in pregnancy, the kidney is a very good, works very well and excretes drugs easily. So therefore, it will be readily excreted. So our first primary outcome was baby's weight, and our secondary outcomes were weight gain, gestational diabetes, preeclampsia, cesarean section, and postpartum hemorrhage. And this is what we did. We scanned the population, 3 hospitals, King's College, Epsom St. Heliers, and Medway, and we had a different kind of ethnic groups, and we ended up with what we wanted, 225 in each group, which was the aim to do the study. And from the baby's point of view, disappointingly, there was no difference in the baby's weight. But we were not surprised, because even if you look at the Irish and the Dutch famine data, even at the worst stage, the baby was not affected in mothers who were pregnant during those years. So actually, to affect baby's weight is extremely difficult. But we wanted to know if this would be important. And there was no difference in miscarriages and Apgar score, so no changes at all. Now, when we come to the maternal outcomes, the first thing that came to our mind that definitely there will be a difference in gestational diabetes. Would you agree? And this is what we found. No difference in gestational diabetes, but there was a 76% reduction in preeclampsia and 27% reduction in weight gain. So this was massive for us. And because of that, we managed to publish it in the most prestigious journal in the world, the New England Journal of Medicine. And the reason for that is because nobody has ever found a drug to have such an impact or any intervention in pregnancy of that massive impact. But I recall, and I remember I was on holiday in Crete at the time when I got the letter from the New England Journal of Medicine. You probably have once in your life, if you're lucky, to publish in New England Journal of Medicine. The editor insisted that in the abstract, we do not say that metformin reduced preeclampsia, because it was a secondary outcome. So he said, if you're going to put that in a New England Journal of Medicine paper, everybody next day will start giving metformin. And it was not powered for that. You need 2,000 patients to power for that. This was a secondary outcome, and that's really important to emphasize here. So the question really, we wanted to know, how come there was no difference in gestational diabetes? How come preeclampsia? This must be not through insulin resistance. It must be something else. And we already know that metformin has other benefits other than insulin resistance. So what we did, we looked at the insulin levels at the HOMA-IR in the patients who had metformin versus placebo. And you can see here that the patients who had metformin had less insulin resistance. But then when we looked at the patients who are preeclamptic and not preeclamptic, there was no difference. So we therefore concluded it's not an insulin effect that led to the reduction in the preeclampsia. And we published that paper confirming that. Now, one of the difficulties I find when I go to the US giving talks about metformin, that metformin is not a very well-liked drug across the pond. And they always challenge you that there is some issues with metformin. Now, I am a very simple man. I always say that if there's a drug that's been around for centuries, over a century, and it hasn't really shown us to have any abnormalities in the baby, I'm sure it's fine. And it's a very widely used drug. But let's look at the literature. So the MIG tofu trial, which was done by Bill Haig and Janet Rowan, showed that the babies exposed to metformin had more subcutaneous fat, but similar overall body fat at the age of 2. And then at the age of 7 to 9, they found that the similar total and abdominal fat and metabolic rates in the offspring, but the metformin-exposed babies were larger in size at 9 weeks. So that's created some anxiety about whether actually it will have a negative impact. Now, we did our work as well, and what we have found in our babies that there was no difference. On the contrary, we had better outcomes on the babies who were exposed to metformin, who had a positive impact on their cardiovascular benefits. Now, there are lots and lots of studies, but not to bore you, the conclusion of all these trials, as you can see here in orange, that although there are sometimes increasing risks with subcutaneous fat, the babies eventually are absolutely normal, and most of the studies have shown no concerning long-term effects with metformin. Now, what about the new agents, GLP-1 and GLP-2? These are new common drugs, which unfortunately, for now, we cannot use in pregnancy. Not only that, but we advise our patients who are taking Ozempic or Mounjaro or Wegovy is to stop pregnancy 3 months, to stop the drug 3 months before start trying for a pregnancy. That's what the current literature tells us. Now, this has been a game changer for obesity for women. So if you're seeing someone preconception, this is a good time to discuss with them using these agents if they want to fall pregnant, but advise them they need to have proper form of contraception before they start trying for a pregnancy for at least 3 months. And it has made a huge, huge, huge difference. Now, there is limited data because a lot of patients do fall pregnant, as sometimes they do, while taking these medications. And so far, evidence suggests that there is no fetal risk, although in animal studies there is, but in humans, we have not seen adverse pregnancy outcomes. Remember in the good old days when we were worried about simvastatin and the statins in pregnancy? But now we use statins in pregnancy absolutely regularly because we discovered eventually that they're not that risky. But for now, we need more research. I can't see anyone is going to be doing a trial of GLP-1 and GLP-2 injections versus placebo in this current climate of the drug. But what will happen, we will gain experience with time of people who fall pregnant and report that. So if you come across patients who fall pregnant on Mounjaro or Ozempic or Wegovy, please make a record of it and try to maybe join up in Jordan and make a publication, because that will be helpful to the literature. So GLP-2 is really important because it plays a gut barrier integrity and nutritional absorption. But I remind people that for me, metformin is the first GLP-1 drug that existed because it has that benefit of reducing glucose absorption, it affects your appetite, and reduces gluconeogenesis, which is basically what these new drugs are doing, but they're doing it in a better way. What about myoinositol? Myoinositol is a fantastic drug that is actually people have underestimated. We use it a lot for polycystic ovaries. I remember a couple of years ago, I don't know if Khaldoun Khamais is still here, he gave a very good talk on the use of myoinositol in polycystic ovaries. And it is safe to use in pregnancy, and we've definitely seen improvement in patients with GDM. Very promising. Bariatric surgery, you can't do it in pregnancy, but the potential benefit is doing it prior to the pregnancy to severely obese patients. And of course, there are other investigational drugs that are currently being considered for that. So let's remind ourselves about the bariatric surgery. Gastric bands, in my opinion, overutilized sometimes. In the UK, I know my bariatric surgery colleagues have told me that they're now removing more bands than putting new bands. And then the gastric sleeve is the most popular surgery, and we have, of course, the mini bypass and the gastric Leroux. Important information about bariatric surgery, that if you have had bariatric surgery, there's an increased risk of small for gestational age, so therefore keep an eye on the baby's growth, preterm birth, and premature rupture of membranes. But you reduce preeclampsia, you reduce GDM, and delivery complications in general. We always advise our patients to delay pregnancy for at least 12 to 18 months and make sure they use a proper form of contraception in these circumstances. If they have a band, you need to release the band before they start pregnancy. So, what about non-pharmacological innovations? Femtech is gaining a real acceleration, and we've heard some of our colleagues speaking about the use of digital apps. I think it will be helpful, as well as personalized nutritional agents. Then, of course, we need to change our healthcare systems, how we integrate these care models, how we can bring all this together about the nutrition, about the drugs, about the exercise, and how we get this to work with our midwives and our clinicians. But we need policy interventions to improve this obesity outcome, because this is something we need to start from school, educate patients about their fertility and weight and nutrition. There are ethical considerations to consider here, where we need to balance between autonomy as well as not shaming. It's all about how we prescribe and which interventions we use, and then what will be the future needs to go ahead with this personalized medicine approach. And I believe the way forward for all medicine is going to be based on genetics and metabolics, because each one of us behaves differently. We need to know which patient will benefit from metformin, which benefit, as it was mentioned yesterday about with Paul, which patient will benefit from having a stitch. It's not almost just about the measurements. There are other things that we need to consider. And I think this is going to be the long-term future directions, is how we keep doing what we're doing, but in a better way. So to conclude, obesity is a global epidemic. There is no currently concrete evidence in pregnancy apart from multidisciplinary approach. I think you need to aim for reducing weight gain, because I think there is definitely evidence for that. Always give advice about lifestyle and exercise. I think metformin is a very reasonable drug to use, especially on what we call super obese patients. This is patients who are above a BMI of 40. I think you should consider that. Or someone with a BMI above 30 with coexisting gestational diabetes or hypertension. They will certainly benefit, or polycystic ovaries, from having these drugs. GLP-1 and GLP-2, I think we need to await the literature and research. They will be a game changer if we can use them in pregnancy. And then, last but not least, a multimodal approach combining lifestyle, pharmacology, behavioral strategies, and this is what I think it will look like. This is going to be the genetic stratification that I mentioned earlier when it comes to cholestasis. We need to know where you are. Do you have the fat gene? We need to know the polygenic risk. We need to know the metabolic risks. So you need to have who has hypertension, who has inflammation, because not everyone with the same BMI behaves similarly. And this will give us this kind of approach where you have a precision exercise. What kind of exercise these women? We also know some people really respond well to exercise. Some people build up muscle very quickly. Some don't. You see them in the gym. Biomarker monitoring, macrobiome, I think, will also have an important association. And then the wearables made a big difference, and to actually monitor your heart rate, your resting heart, as well as involving all people from the society. So we need to make sure that the equity focus, so not only the rich people who can buy these wearables should have accessibility to that. Thank you very much.
We have time for one question. Dr. Falah.
In infertility clinic, probably 1/3 of the patients who come to the infertility clinic, when you have a female factor, it's PCO patient. How far, we start them on glucophage. Personally, I start them on glucophage, and I continue on glucophage until they deliver. How far would you do continue on a glucophage treatment rather than starting on the week 14, as you say here. Would you continue the same regimen of glucophage from the start up to the end, or what's your recommendation?
Thank you. So the patient we started 12 weeks, this was a study. So that was a different reason for it, because that was a study. I think it's a very good question. So if you look at the role of metformin in infertility, interestingly, it has shown some benefit in patients with polycystic ovaries who are slim compared to people who have polycystic ovaries who are overweight. And that was a little bit of a confusion because everybody thought it will have an impact otherwise. Now, what it has done, it has improved hormones, but it has not really as much increased live birth or reduced miscarriage. But what it certainly has done has improved the metabolics of the woman. So I agree with you. I think if you have somebody with a very high BMI coming for fertility treatment, obviously apart from you need to advise them to lose weight, that you could consider using metformin, and I will use it pre-pregnancy, and I agree with you, I will use it throughout the pregnancy, because my aim is for them to avoid that weight gain we mentioned about, and hopefully reduce the risk of pregnancy-induced hypertension or preeclampsia, because these women who are high BMI, in particular if they end up with multiple pregnancies, then they will be at a higher risk of that. Thank you.
Thank you very much. Dr. Maher will introduce our next speaker. Thank you very much, Dr. Hassan.
Can I call on Professor Paul Fogarty, who's been introduced before? He's going to talk about a very important subject, especially for people who work on the labor ward, shoulder dystocia, where, when, and how. Please, Professor. Thank you.
Thank you very much. That's the right one. Okay, thank you very much. So, I hope you're not getting bored with these double acts, but I want to talk about a very important clinical problem on my slides. Can we go to the next slide? It's not working. Okay, thank you. So he just showed you my suprapubic arch from my last visit to Wadi Rum, which you will be very, very familiar with. The reason I like to talk about shoulder dystocia is that it's often one of the loneliest places in the world. If you look on Google for the loneliest place, it's somewhere in the South Atlantic, or it's in a Humphrey Bogart movie. And I remember as an SHO, when I first did a manual removal of placenta, my boss said to me, "It's very lonely in there because we don't know what you're doing with your hand." But I put it to you, ladies and gentlemen, that there is nothing more lonely than in a room when a baby's head is delivered and nothing else is coming out. It is terrifying for everybody. So over the next 20 minutes, I want to summarize these learning objectives for you. Understand, I think most of you will know the definitions, some of the risk factors, apply a structured stepwise approach, how to document, debrief, and how maybe to prevent it happening at all. It's interesting that many of you will be familiar with shoulder dystocia, but actually the definition is very simple. It's failure to deliver with gentle traction. How do you define gentle traction? That's quite a difficult one, isn't it? And I couldn't repeat some of the phrases people have said. Yes, you shouldn't. It's like when you're pulling on a forceps. No one writes severe or strong traction. They write moderate traction. Okay? No one ever pulls very hard. The main risk, of course, is well known to us all. And then you may think that, following on from Hassan, this happens with big babies. It's not as simple as that. Previous shoulder dystocia does recur. It often happens if a baby is more than 4.5 kilograms and if they're diabetic and if they're heavy mums. So that's why it ties in very nice. But actually, there's many, many other risk factors. And this is where you need to have alarm bells and flags going up in your clinic, in your labor ward. If you're seeing a patient, which is particularly a Paris patient that is laboring perhaps a little bit too longer, and have this vigilance. And of course, it's the Erb's palsy, which will cost you and your insurance company millions of dollars. Okay. The risk of brachial plexus in your fetal weight, though I alluded to, is not clear. It's interesting that it's 9% of babies weighing more than 4 kilograms, 80% in that next window of 500, and only 26% in 4.5. So it's not that easy. But this next slide, it really makes you step back and think, oh, so the majority of babies over 4.5, that's 75%, do not experience shoulder dystocia. That's important. Particularly whenever you start saying, when we're moving on to the second half of this talk on counselling, when you have a baby that estimated fetal weight is 4.6 and you're advising a cesarean section, you have to think of your data very carefully. And 50% of shoulder dystocia occurs in babies that are smaller than 4 kilograms. So we are in a real conundrum. I'm going to talk a little bit about this sort of borderline grey area, which is the 4 kilogram plus baby. And it is associated with risks, particularly for the neonate and particularly in diabetes. And what I'd like to know is, and what I'd like to discuss is, how do you advise that woman in that grey area? I don't think any of us would have the discussion with a 3.8 kilogram baby or a 4.7 or 4.8 kilogram. But if you're sitting at 4 kilograms or 4.1, what do you advise? The options are, certainly there's very clear guidance on the bigger babies, particularly over 5 kilos. However, there are no recommendations that I could find on that care in this grey area. We have obviously changed our practice in the UK after the Montgomery ruling, where women should be provided with information about potential risks and benefits. And the 3 options are expectant care, induction of labour, or a planned cesarean section. And I always think it's a bit unfair to say to a woman, there's your choices, you make the choice. They come to you as an expert to guide them. And you should be able to say, here's the risks, what do you think about it? Go away and think about it at home, come back with your partner, and look at those options. Because those options are not that easy sometimes to tease apart. First point, there's early induction labour. How early is early? 37 weeks, 38 weeks, and then you've got to balance that against this baby then that's in special care with severe respiratory distress. Do you plan cesarean section and then she ends up with severe complications, not maybe in that pregnancy, but in the next one? And you need to actually put that all in, and how do you balance that? So there are some good trials on induction of labour at term for suspected fetal macrosomia. I've summarised it here for you. Induction of labour, 40%, this is in the just over 4 kilograms. Induction of labour, 40% reduction in shoulder dystocia, and an 80% reduction in fractures. But there was no significant difference in the rate of cesarean section. But Rani, I'm not sure if she's still here. You know, and this is something we now have to talk to our patients about, is perineal trauma. I mean, that can be a devastating injury as well. So this is the problem. When it comes to giving patients information, it's always nice to get written information, and there's some nice information available. That's an infographic which is available, and it compares the options. But a lot of statistics in it, not suitable for every patient. But that's something that your bigger hospitals and general, and maybe the Jordanian Society should be looking at, is some guidance for their patients. So what do you do when that shoulder gets stuck? Okay. I've highlighted the first thing you do when you recognize it is you call for help. You don't start pulling, all right? There will be signs, the experienced ones in you, but I say a lot of the normal deliveries may be done by midwives, so the midwives need to identify the heads fail to rotate, there's a turtleneck, and they need to actually say why they're calling for help. It is shoulder dystocia, because often there's a breakdown in communication. They don't want to alarm, your midwife doesn't want to alarm anyone, so they say, could you come and help me, doctor? And they need to tell you exactly what's going on. Stop the mum pushing, because actually just the mum pushing can be just as damaging. I don't think I need to go through all of this, but if you want to click a picture of it, it's all available on the RCOG website. And this is fairly standard But we don't do it standard. We panic if you haven't trained in this lonely place, the labor ward with a stuck baby. You start panicking, okay? Yes, the clock is ticking, but you will do more harm if you start panicking. But the key principles are: don't pull, do not repeat unsuccessful maneuvers, all right? That's really, really important. If a maneuver works, great. If it doesn't, don't try it again. Move on to the next one. And be methodical about moving through them, okay? How do you remember them in this situation? You have it written on a piece of paper in the labor ward. I'm going to show you some examples where on one side you have the documentation and the other side you have your sequence of events. And that is so important, because whenever it comes to litigation, you can then say we followed the rules. Very important to designate a leader. It's not often, may not be the most senior person in the room. It may be the person who's just been trained in shoulder dystocia. You've just come back from a course and you know how to do it. But we as seniors in the room often come in and like, oh, gee, I haven't done a shoulder dystocia in years, as you, whereas the registrar has done 3 in the last 6 months. So make sure, I say, that you define who your leader is and a scribe. Someone needs to be standing to one side recording everything, okay? Obviously, if you do, your maneuvers will be successful most of the time. It's important that you don't relax, which is the normal thing. You say, phew, we got away with that one. Let's go and have a cup of tea. The baby needs to be assessed. The mother needs to be assessed. You must document it and you must debrief. Now, the debrief for your staff may be immediately afterwards, an hour later, or the next morning on the ward round, but certainly the debrief for the patient is probably best done, on my advice, is the next day when she's had a chance to recover and you know the baby's doing well. Now, I refer to the documentation. Again, this is very, very available in the RCOG guidance. So you'll see there on the right side, the sequence of events, okay? And on the reverse, the documentation. You should have lots of those in your in a folder in your labor ward, okay? So you're not trying to work it out from memory. The documentation tells you who was present in the room, what time they came at, when they arrived, the time the baby's head was born, and the time their body, which shoulder was the anterior one, because a baby could have an Erb's palsy in the posterior shoulder. That would make you wonder, have we got something, is there something else going on here? Timing of the maneuvers and the maternal trauma and neonatal condition, including a blood gas. If your unit doesn't do routine blood gases, my unit, we just did blood gases in everybody. It was just easier to do that. Please do your blood gases to see what the baby's condition is like. These maneuvers, I say, are really important, and that's where I hope we have time to talk about the training and how you train. I know I've been talking to some of your colleagues about some links with the RCOG and the Irish College about organising training locally. But RCOG recommends there should be annual multidisciplinary training, okay? Certainly our registrars, our midwives will train on a shoulder dystocia at least once a year, often more than that. And please remember your staff that are on night duty. We always do the training drills in the afternoon or in the morning, and then we forget shoulder dystocia happens at 1 a.m. sometimes. We emphasize leadership, communication, and rehearsing the maneuvers on your simulators. And by doing that, your litigation may still happen, but it becomes very, very defendable. So I can't emphasize enough the training. I don't know if this is the right document, but this was the Jordan Emergency Obstetric and Newborn Care Assessment. It's quite a big PDF. I couldn't find any reference to drills for PPH or shoulder dystocia, which are 2 major, major emergencies, which you need to practice and learn from them and do them again and again and again, okay? And that applies to me and everyone, no matter what your age, senior or junior, you do the drills. We have to lead by doing the drills, okay? So I'm going to refer to the prompt. I've got 5 minutes, which is a well-recognized training system which the RCOG endorses. And again, we train the maneuvers on dolls, how to press properly. Pringles were mentioned yesterday by somebody. The Pringle maneuver is how you put your fingers and hand into a Pringle jar to get the last crisp out. I always turn it upside down myself, so I don't know. But it's back down to getting that maneuver right. And they have done, I mean, our colleague and Vice President in the past, Tim Draycott and the Bristol team have got amazing results from this, and it's all over the world now. 50% reduction in hypoxic ischemic encephalopathy, 40% reduction in cerebral palsy, 100% reduction in permanent brachial plexus. I mean, it speaks for itself. And the secret to this is not just multidisciplinary, it's team training. All the staff need to be trained, not in a centre, but in your own hospital. Practice how it works in your own labour ward. And there's the middle bullet point there. You'll see huge reductions by just a short 40-minute training. You can get 83% were able to successfully complete the birth. Okay? So my take-home messages, Mr. Chairman, Madam Chairman, shoulder dystocia, yes, will happen in big babies, but it also happens in smaller babies. It's unpredictable, so be ready. Have everybody in your labour ward ready to call for help and communicate clearly what the problem is. Follow helper. Avoid traction and certainly no fundal pressure. Document it clearly. Debrief your staff, debrief your patients, and train everybody regularly. And by doing that, the loneliest place on earth will hopefully become a very happy place. Thank you very much.
Thank you very much, Paul. Just to tell you, we do that also here in Jordan,
Okay.
and we organized a special course called Saving Maternal Lives with the help of Professor Hassan Shahata and his team. And we've done how many? 4 or 5 courses? So, yeah, and shoulder dystocia is one of the main stations,
course,
and we
yeah.
target junior doctors, residents, and junior specialists. And we do it once a year, and we have a team coming from the UK.
And do the senior specialists do it?
Say again?
Do the consultants do it, the senior consultants?
Yes,
Good.
if they want to join in, they're
No,
quite
no, they
welcome
shouldn't be
to.
wanting. They have to do it because they will be the leader. That's
Yeah.
what I'm trying to say.
Absolutely.
It's embarrassing, but we have to do it because if we don't do it, everyone looks to us and you go, I'm not sure.
Yeah.
But actually, it's good fun. I
Sure.
enjoy doing also
Yeah.
courses. Get stuck in, as I say.
Absolutely. Do we have any questions for Professor Fogarty? Any questions? So can I just ask you, please, Doctora, تفضلي. Can we have the microphone? Dr. Abdel Fattah? It's okay.
I used to teach my students about the helper.
Yes.
For me, the last R, I cannot imagine. Usually I omit it. So I cannot imagine how you will turn the patient on her abdomen. Everything will be disarranged in my mind.
I know, yes.
How you feel about this, the last R?
It's again, practicing. Actually, and a lot of our women now will deliver on all fours. And of course, our colleague, President of FIGO, has lectured all over the world on delivering breeches on all fours. Yes, it does reverse the anatomy, but it's fine. It works. Yeah, it changes the angle. It opens up the pelvis.
Doctora,
Yeah.
Doctora.
The R which I struggle with is replacing the head and doing a Zavanelli maneuver. I don't know. I've never seen one. I've never done one. So that's why I don't talk about it, because has anyone actually pushed the head back in and done a cesarean?
Okay, Doctora, تفضلي.
Okay. It's written in books, but yeah, it's maybe an urban myth. I would like to know.
Yeah, go ahead.
Maybe Hassan or somebody can help me have this.
يلا.
If any patient have history of a previous shoulder dystocia, is an indication for next pregnancy to go for cesarean section directly?
That's a very good question. There will be a very strong evidence there that the recurrence will happen, but it will depend a lot on the size of the baby, and you may consider with counselling that a planned induction is acceptable at maybe 38 weeks. Okay, and also depends on the gender, on the different size. Every pregnancy is different, so. But if the difficulty is if they've had a shoulder dystocia for 3.5 kilo and this baby next one is the same size, I think most of us in this room will be sensible and say, let's do a cesarean section. Yeah.
Paul, yeah. Just two quick questions. I mean, you know that we are very bad at estimating weight of the baby on scanning. The sensitivity is not very good. So that's one point. The other point is, do you think any case of shoulder dystocia is counted as medico-legally, I mean, it's a problem as a medico-legal case? Or if you followed the guidelines and the protocol, then you're okay if the baby ended up with a brachial plexus problem?
Yeah, that's right. Ultrasound is inaccurate, and particularly in a heavy woman. But if you have a baby who's 3.5 kilos and has, in a normal-sized woman, and has a shoulder dystocia and a nervous palsy, but if you haven't followed it and documented it, that case will they will settle that case because you can't defend it. But the famous saying our lawyers say, if you haven't written it down, it didn't happen. That's why it's really important to document it and get used to documenting it. I'm not saying video record it, but I think you need a scribe who was writing down the times. And then you can defend it. You say, well, this happens. It's an accident. It happens. It can be defended, yes.
Okay. Dr. Falah, last question. Can we have the microphone, ya Shabab?
Shoulder dystocia could happen with very small babies, less than 2.5 kilograms, and even it could happen with cesarean section. If you don't know how to deliver the baby with a very small incision, cesarean section scar, you might end up with shoulder dystocia and probably brachial plexus injury. Yeah. All of the medical legal cases where shoulder dystocia was considered or was claimed as a medical legal problem, we usually sympathize with the doctor who is faced with this case, because the possibility of error in weighting the baby by ultrasound might vary, especially at the end of pregnancy, third trimester. It might be more or less 15%. With any ultrasound measurement. And most of us are really, the ones who deal with the deliveries are the junior staff, the junior residents, and the consultant is really not available at the delivery at that time. So usually we sympathize with the patient, knowing that 90% of the shoulder dystocia, they will end up with spontaneous recovery rather than 10% they might have some sort of damage.
Well, the lawyers will not have sympathy, I'm afraid. So that's why you have to be trained and have evidence that you're trained.
Well, we'll keep training our residents.
So,
yeah. But this is a very important thing. Shoulder dystocia has now been well documented at cesarean section. So just be as gentle. It's back down to, it's us pulling on a baby's neck, which is causing the problem.
Yeah. You know, we just tell the residents, the way you deliver, about breech delivery. If you know how to deliver a baby breech through a cesarean section scar, you should be good enough to deliver a breech vaginally, but you have to know the steps and take the same procedures and steps. And the same thing, if you know how to deliver a baby cephalic without shoulder dystocia, without injuring the baby through a cesarean section scar, probably you will be good enough to deal with shoulder dystocia if it happened with you. So it's a continuous learning and continuous teaching and learning all the time. Thank you, sir.
Thank you very much, Professor. Thank you.
Okay.
Bye-bye.
Thank you.
Now we are back with Dr. Tom Bourne to talk about the psychological impact of early pregnancy loss.
Thank you very much. Let me just get the slides up. Right. Ooh. That was slightly unexpected, but I survived. The tricked step. So, I only just got back here. So, I just had, come on, come on. As you can see, I was taken there for lunch, and look, I have no food on my suit, so I think I deserve some credit for this. And I also managed to eat this before dinner last night, so I think, thank you so much. Right, anyway, we digress. I'm going to talk a little bit about a more serious topic, and that's obviously about miscarriage and the psychological impact of miscarriage, which I think is something which has been largely ignored. And actually, when you look across what I'm involved in, whether it's early pregnancy or fetal medicine, if you go to a fetal medicine conference, there's never anything about the psychological impact of what they are doing Although more recently there has been interest in early pregnancy loss. Now this is a painting by Frida Kahlo, which she is painting when she lost her baby at the Henry Ford Hospital, Detroit. And it's very symbolic. You can see here her pelvis, which she feels failed her, the flowers her husband Diego Rivera gave her, the machine that took her baby away, her baby, and the snail, which is the very slow pace with which the doctors dealt with her in her eyes. But I can talk to you about the psychological impact of miscarriage, but I'm unlikely to do it better than one of the greatest artists of the 20th century. This is a woman who could deal with a lot of pain. She had a major coach crash when she was very young. She has metal pins in her body, and she had major health problems throughout her life. But it emotionally impacted her for the rest of her life. So let's just go through a few things. I'm going to talk about what the size of the problem is and some data relating to, which is unpublished, which might answer one or two questions. First of all, what's the size of the problem? Well, we published this back in 23, I think. I can't remember now. No, 20. My PhD student, Jessica Farron. This is 900 women, 700 approximately with a miscarriage or ectopic pregnancy, and 170 viable pregnancies, which are controls. So, I'm just going to ask you to focus on one thing, and that is PTS, i.e. post-traumatic stress. So this is the percentage of women with moderate to severe post-traumatic stress symptoms consistent with post-traumatic stress disorder. And you'll see that at 1 month, almost a third of women have got moderate to severe post-traumatic stress symptoms. And this reduces over time, but by 9 months, still, it's about 18 to 20%. So let's just say roughly a fifth. That's 9 months after the event. Yes, there's a high level of anxiety, which reduces over time, and depression that reduces over time. But I want to focus on post-traumatic stress, and I'll explain why. Just hang on to that number. And it's not just, in fact, something that impacts on the women. In this case, you can see we also looked at partners. And although that doesn't look like a very high number, again, 4 to 5% at 9 months of the men also had moderate to severe post-traumatic stress, having either witnessed the miscarriage or whatever. So we're talking about 1 in 5 women having a debilitating psychological problem, and 1 in 25 men. Anxiety and depression both largely resolved, particularly depression. But this is a serious, serious problem, actually, as I will discuss now. Because if you look at other data, this is early pregnancy loss in a paper from Spain, you can see here 3 years after the event, this is post-traumatic stress disorder, 1 in 6 to 7 women have post-traumatic stress disorder 3 years after the event. And there's quite a lot of evidence that if untreated, it never actually resolves itself. And you will speak to people, or women, years after the event about their miscarriage, and they'll break down in front of you. Why? Because it's never been properly processed. And that's why it matters. Because if you look at the fact that there are 23 million miscarriages each year, that's 3.5 million women with post-traumatic stress 3 years later still, every year, accumulating in a population. In the UK, it's about 30 to 40,000 women. So this year, 3 years on, you're going to have 40,000 women. The next year, it's going to be the same. And if you think about the numbers of people who are being impacted over time and the social and economic impacts of that, it's actually quite shocking. Now, I accept that this is data from London, but it's a highly diverse population where we work, a big background. And I do know that people have actually done some work on this in Jordan as well. They haven't used these metrics, but they have shown high levels of distress. And again, I'll talk about that. And it's not surprising, perhaps, that after pregnancy loss, you do see that there is an increase in breakdown of relationships, marital breakdown. And we know that if people have post-traumatic stress symptom, they will also have a higher likelihood of their relationship breaking down, of failing at work, and almost descending through society's scales, really. And you see that with soldiers. And actually, if you look at people who go to war, because I know my brother was in the army, and 20% of people who go in a conflict zone, 20% will get post-traumatic stress disorder generally. And you get about 20% of women get post-traumatic stress disorder after miscarriage. So obviously some people are susceptible, but that's the kind of number that you come across. And that's not the whole story. It's actually just the tip of the iceberg, because when you talk about post-traumatic stress and fulfilling the criteria, it means you have to cross a threshold, which is obviously not totally dichotomous. It's not suddenly you have it or you don't. If you're beneath the threshold to say you've got post-traumatic stress disorder, you are also going to be symptomatic. And if you look here on the right-hand side, the women here, you can see, look, I mean, how many of them, 58% still feel terrified, helpless, they're getting re-experiencing avoidance, they won't meet friends who've got babies, they can't face it, they don't want to know, they're having issues with relationships, sex life, satisfaction in their life, and so on. It's having a major impact on their ability to actually go about their daily life. This is not a minor problem. Because you have all of these things going on, it impacts on relationships, you get physical comorbidities, because people have more likely to have cardiovascular, metabolic, gastrointestinal problems, psychological issues, which I've discussed. It also, in fact, is known to impact on future pregnancies. We know that if you have post-traumatic stress in future pregnancy, you're likely to be more likely to have prematurity, low birth weight, and worse perinatal outcomes. So it's impacting across the board. And when we published this data, it went into the media, I don't know why particularly, because we didn't push it into the media, but it was taken up by the media. And I think it kind of allowed people to talk about this, because people don't talk about this. Certainly in the UK, women are told, well, don't tell anyone until you're 12 weeks and you've had a scan. So of course they miscarry, and they've got no one to talk to, because no one knew. I think someone described it as Schrodinger's pregnancy. It's there, but it's not. So it's a very odd place to be, I think. I don't know what the custom is here, but that's certainly what happens in the UK. But this is a paper from Jordan, I just found, which I thought was interesting. It's 2023, so reasonably recent. And I don't think they looked at metrics to look at post-traumatic stress, but if you look here about their reaction in Jordan, women in Jordan who have miscarried, the number who have felt ashamed, lonely, guilty, they've felt that they've lost a child, and then so on. There's a fair, it's a significant number. And 50% have asked for social support in the cohort in this paper from this country. So whilst I can obviously say that we haven't carried out the study in Jordan, I think there's some evidence to suggest that it would be reasonable to say that similar things may well be happening here as well. There's no reason to believe it isn't. Okay, so people always want to know why. First question you get asked, why have I miscarried? And we kind of say, well, it's probably a chromosomal problem or whatever, because we think that's the case. But we can't tell people that's the case unless you send tissue off. Half the time it doesn't get there or it doesn't work. However, what about using cell-free DNA? I think most people think now, because we do NIPT testing, and we say, well, it's not going to work at 5 or 6 or 7 weeks because you won't have a big enough fetal fraction. But very quickly, because I know I haven't got a huge amount of time, this is a prospective study, 300 women at time of miscarriage, where we've got matched pregnancy tissue sent for conventional assessment, and then blood for what is effectively circulating fetal free DNA using the Illumina platform. And so we basically looked and seen if these are comparative. And first of all, if you look on the left, you can see that the cell-free DNA result got a positive result in 98% of cases, which was a surprise, because we expected that it probably wouldn't work. And then if you look on the right-hand graph, you can see in green is where you've had a successful result, and you can see that the results are pretty uniformly the same right across the board, from 5 weeks. So, and this is just not changing any of the thresholds or the algorithm It's just conventional Illumina. I'm not pushing Illumina. We think it'll work with others as well, but that we were supported by Illumina because they gave us the reagents for free. And so you can see that using this platform in women who are miscarrying, if you look across on the right-hand side where we've excluded non-detectable abnormalities with the Illumina platform, it has an accuracy of 86%, sensitivity of almost 80%, but 100% specificity positive predictive value and no false positives. So in other words, if you have an abnormality, you can say that with 100% certainty. Now, does it matter if you miss some? Not really, because we're not talking about ongoing pregnancies. But it means that you can tell most people, if there is a chromosomal abnormality, that that's what's happened. And you may say, who cares? It doesn't change anything. It does for the women, because then they know why it's happened. And they, as you saw from even the data from Jordan, that takes away the guilt and the shame and so on. It's not their fault. First thing that most people say, is it my fault? What did I do? And you can say, no, it completely wasn't your fault. We know, sadly, this was a chromosomal problem, and that matters. This is performance by gestational age and sensitivity and specificity. And interestingly, I expected it to be successful if there was an embryo maybe, but probably not if the miscarriage, when you took the blood, was an empty sac or retained tissue, and it actually made no difference. It didn't make any difference what the scan findings were. It made no difference what the bleeding score was. Because we thought, well, if the uterus is emptied, how would you have... But it doesn't make any difference. So I think there's every reason to believe that in a large number of people, we can use this to give at least some answers. Okay, can we prevent it? Well, you know, obviously, it would be good if we can reduce the trauma that people feel. And undoubtedly, there will be things that do that. You know, what sort of management? We all think it's great that we have expectant management and we don't do surgery, but for some women, that is going to be traumatic, and that's the wrong thing to do. We just don't know which ones always, but that's a judgment you have to make. And I think you know, it's individualized. But can we actually reduce the most intrusive memories after early pregnancy loss? Now, we found that there were some papers from someone called Emily Holmes who was using Tetris. We'll come on to that, which is like a game, computer game. Who can remember that game? Anyone over a certain age? But anyway, she was using Tetris not in early pregnancy. This was after road traffic accidents, and showed that the number of intrusive memories could be reduced by Tetris game playing after the event. It sounds insane. You're dying with laughter, but it's true. So here we have it. Tetris, so if you remember, you rotate these blocks and drop them in like this. So we randomized these patients to the intervention, which was playing Tetris, but in a structured way. We teach them how to do it, and they have to mentally rotate and focus to mentally rotate Tetris. And it takes about 15 minutes to do this. And the control group listened to a podcast, something very boring, don't know what, can't remember what it was. But anyway, just have a look. If you look, average number of intrusive memories at week 5 were reduced in the intervention group by over half. And at month 3, the rates of psychopathology, post-traumatic stress, were also reduced by over a half. And this is in a randomized trial. So, and then we're now following them up to month 9, and we're finding a similar effect. So this is consistent where people have used Tetris game playing, stop laughing, Tetris game playing to impact on post-traumatic stress symptoms. And it impacts in some way on how the memories are embedded. And you'll say, when do you do it? It doesn't seem to matter. At the time of diagnosis, you see them and then you do this. But obviously when they come to see you, they'll be at different phases. They could have miscarried at home a day ago. It didn't seem to matter. This is entirely consistent with other applications of using Tetris, bizarrely. But if you can reduce that 20% to 10%, that's actually well worthwhile. So different, but something to bear in mind, and I think this is something that people will start talking about a little bit more. So finally, can you identify and treat those people who've got psychopathology? Because we're probably not going to offer treatment to everybody. How can you find these people? Because the problem with post-traumatic stress is that most people with miscarriage are offered support groups or talking to their friends or non-specific counselling. And if you look at, there's a Cochrane review, and it said that basically counselling was of no value to people in this context. But the reason it's no value is because they're applying it to the wrong people, because if you have post-traumatic stress, you need specific treatment, which is trauma-focused CBT or eye movement desensitization, coupled with some sort of drug treatment maybe. It's not going to get better by simply the usual thing. Most people will resolve a lot of their anxiety and depression by having support from their family and friends and all the sorts of things you'd expect. But this is pathological. It's an inappropriate response that needs an intervention. So you need to find them. So first of all, we thought we could look at risk factors. I won't bore you with the paper on the left, but basically we were not able to identify the high-risk group, possibly a slight increase, not surprisingly, if you've had fertility treatment, previous miscarriage, and if you have a pre-existing mental health disorder. I mean, no great surprises there. We probably could have come up with that without doing the study. However, what you can do is actually see if women will take up screening. So if they've had a miscarriage, we initiated a study where we've got the pilot data, 500 women. People don't engage. Not everyone will want to reply. So we sent a text to women, and we asked them to fill in a Core-10, which is a validated instrument which you use to diagnose post-traumatic stress. And at the end of this, people who responded, we ended up that 16% of all the women sent a text message we identified as having moderate to severe psychological distress, which is almost the same number as we would expect to see. And of those who we've seen, 75% have shown significant clinical response to treatment. So there is a possibility that women, just by, if you're in your clinic, you set up a system where they get an automatic text, you screen them. If they're above a certain threshold, you offer them psychological support and an intervention. And you'll hopefully pick up most of the people who are most at risk. So we can show it. And then finally, very quickly in my 1.5 minutes, it's all very well, we look after what's happening with these women, which I think is a hugely underserved population. But you've also got to think about what's happening to the people who are looking after them. Because one of the problems, I see all these maternity reports and all the rest of it, and also people who are looking after people in early pregnancy. Compassion and actually caring really matters. But if you're not well as a doctor, you're not going to look after people very well. So just for interest, because it might be of interest anyway, this is a study published this year in ACTA, which we did, and it's burnout and well-being in gynecologists before and after the COVID pandemic. Now, on the left is 2022, but I'm just going to focus over here. Sorry, on the right is 2017-18 pre-COVID, and 2022 is on the left. If you look at burnout, and let's just focus on trainees, before COVID, 43% of trainees exhibited or had the criteria to be burnt out. After COVID, it was 80%. 80% of trainees in the UK. 72% of SAS doctors, 67% of consultants. Now, using the MASLAC, this is using the MASLAC burnout inventory. It's not some soft marker. This is a disaster. Why? Because there's absolute clarity that burnout is associated with poor patient outcomes, patient accidents, unprofessional behavior, lack of empathy. And I remember the health minister in the UK, when they were reporting on some maternity scandal, said that basically there was a total lack of care and cynical disregard for the care of the women. Now, the only thing I can think of in that situation is because they're burnt out. Because I do not know many people who've gone into medicine thinking they're going to behave in the way that people are describing. I just don't buy it. Something has gone wrong. You can't look after women who are having a miscarriage or losing a baby if you have no empathy, you have no compassion. So we need to think about that. You need to have doctors and nurses who are well, whose well-being is looked after if you're going to take care of people properly. So think about what's happening there. But if you look not just about that, you can just see some of these other things. Suicidal thoughts, those with burnout, it's very high. I mean, really, it's amazing when that's not being picked up on. But they're also angry, irritable, anxious, having sleep problems and relationship problems. This is not a good recipe. Okay, so I'll close on that. And I just think that's really important because a lot of people here are very senior, and I think it's really important for those of us who are reasonably senior in obstetrics and gynecology to take this issue about burnout, and particularly amongst trainees, extremely seriously. Not only is it a problem now, but if they're burnt out now, how are they going to function later on when some of the people who are in training jobs actually get to be consultants? It's not a good situation for the profession, in my opinion. However, just to focus on women after miscarriage, clearly we have significant levels of psychological distress. We are now in a situation where we could probably start to think about explaining why to a lot of people. We can perhaps reduce the likelihood of having post-traumatic stress, particularly around intrusive memories. And I think we can see that for a lot of people it is acceptable to use screening to look for post-traumatic stress, just using a simple text system with an online instrument. And we found that we could probably identify the majority of the people who are most severely affected. And just a thought about workforce, if you're looking after people who are traumatized, it kind of helps if you're in a good psychological state yourself. And I think that doesn't matter actually about miscarriage, women in labor, or whatever else. So maybe that's something to think about. Thank you very much. I'm sorry I'm slightly over time.
Or a comment? Yeah, Dr. Maher.
Stunned.
Thank you very much.
Where are you?
I think with burnout...
Oh, sorry. Hello. Sorry.
With stress, I mean, it applies to other areas in medicine. If a lady loses her uterus after a cesarean hysterectomy for placenta accreta, I think it's similar.
Yeah, no, totally.
So there are lots of scenarios which this can be applied, really. That's one point. The other thing is we're talking about burnout of doctors, and I remember when most of the seniors in the audience, probably including you, when we used to do lots and lots of hours.
I'm 20,
people will not...
I'm 28.
I know.
Yeah.
People were not talking about burnout. I mean, 20 years ago, when we used to go to the hospital on a Friday morning and leave the hospital in the UK, because most people here trained, go back home on Monday at 5 o'clock. And we were not talking about burnout at the time. Now, less hours, European criteria of doing hours and so on and so forth, and lots of people talk about burnout. So I just want to hear why things have changed over the last 20, 30 years.
Well, I think society's changed and people have changed, especially amongst trainees. I mean, it might be different here, but certainly in the UK, they expect a work-life balance, you see. It's different. And I look at my time as a junior, right? I lived in the hospital. I didn't leave. I didn't expect really to do anything outside. That provided me with peer support, people around me who were in the same boat doing the same thing, who I could talk to about what was going on. I also, in those days, had a firm structure, the old firm, you know, where you had a consultant, senior registrar, registrar. So you had mentorship and you had support, you had people taking an active interest at that time. Now, I know everyone talks about this, and I was talking to Kate Lancaster, just mentioned it, I know she's here. We were chatting yesterday, and she was saying, yes, the firm structure, everyone kind of wants to recreate it because that enabled people to have support and I think talk through things when things went wrong, and I felt very supported. And so I think the structure was different. I know people were tired. I'm not saying let's go back to the old days. Somehow we have to find a way of balancing that. I also think generationally, I think of my daughters, they're different to how I was. I had a very different attitude to my life. They kind of expect to be doing absolutely everything. Work is very different, so it's kind of not the same thing. I also think that it's more intense. I mean, if you look at how, when I was on labour ward and so forth, we would call it high acuity. In other words, it's more intense, there's more tests, there's more stuff going on. You go to a labour ward now, the expectations are higher. I sense more dissatisfaction. I mean, there's so many things I think that have changed, in my view. Both in terms of the support structure, the expectations of patients, the complexity, if you like, of being on call and how busy it is. I think in a lot of units where, you know, a lot of units are consolidated. So, you know, I remember being a registrar at one point, there were like 3,500 deliveries. Now where we are, it's 8,000. Most of it is complicated. So I think lots of things have changed. And I think there's also a fairly toxic environment in a lot of hospitals as well around management and tasks and things. And of course, the trainees are told, well, you know, build resilience. And that's the classic response for people who, it's not about that, it's about not having the environment that creates the situation. Yes, resilience is a small part, but most of it is the environment and the setup that you create. You know, you have to look after these people.
Excellent. Thank you very much. Can I ask Professor Fogarty, back to the stage? He's gonna talk to us about the role of artificial intelligence in medicine. It's all yours, sir.
Thank you, Tom, for highlighting the burnout issue, which is a serious, serious problem, not just in the UK, but all over the world. So it is something which we really all need to be aware of and try and focus on. I have no declarations but my intelligence. The famous wit and Oscar Wilde once said, and I have nothing to declare about the next 20 minutes except a lot of this talk was actually generated by ChatGPT. I'm a very, those of you know me well, I'm an extremely early innovator. We were talking at coffee about buying my first Macintosh in the mid 80s, before Windows even came along. So, and the next few minutes, it's just future gazing. The future is here, and it's interesting already. Yesterday and today we heard Tom Bourne mention ultrasound AI being used for his ovarian masses, and Ahmed using it in the gynae oncology field as well. So it's very nice to be back, and I'm looking forward to some more shisha maybe later on, but I'm focusing actually, I mean, there's so much about AI, but I'm focusing on, this was a clinically oriented session, I'm focusing on gynae and the OR. And of course, you sort of imagine it's going to be something like this, like Star Trek. It won't be there in any of our lifetime. But I've structured the talk today looking at how AI might impact in the pre-op stage, intra-op, and post-op. We have a chronic problem, maybe leading to the burnout in the UK, with massive waiting lists. I mean, it's unbelievable. And gynae is one of the worst. I think knee replacement, you might wait for 3 to 5 years for your hip replacement, and often it's driving people to go to private practice, and that's another debate. But AI can be used and is being trialed to try and predict clinic workload by dealing with no-shows, cancellations, reallocating. That's all managed by your admin staff or your secretary at present. And those of you who, you know, we now use AI booking systems for everything, you know, booking flights and you name it. But it also can be, it can learn, the generative platforms can learn how to risk assess patients and actually can monitor when you're going to have surges in patients. We know that, for example, in winter flu epidemics. We know when staff have holidays, when they go on, you know, there will be various, you know, times when you've got maybe going to prayer, etc. You say, right, let's try and work our workload around that. So the chatbots can take on a lot of the admin's tasks which currently are delegated. We might train a midwife to answer the phone or to do the follow-up for miscarriage. And a lot of that can be now done remotely and automatically. And similarly with reviews. When it comes to the actual patient, I'm a great believer. I'm passionate about consent and making proper informed decisions. And there is no doubt that we can use AI tools to help guide the patient through the choices. And they can do that on their iPad at home in a low-risk environment, no pressure. They're not being asked to sign a form. They're being able to discuss it, okay? So it really does help the decision-making, and it makes it tailored to that patient's specific risks, because every patient will have a different risk. So it personalizes it, and it will answer the questions. The only issue, and that's one of the downfalls of ChatGPT, is it likes to give you positive answers. So I'm not saying ChatGPT is the answer here, but these sort of models. I asked it yesterday. What did I ask it? I asked my other declaration is, it's my default, that's what I search with everything now. I use ChatGPT. And it's remarkable how it's getting better and better. But I asked it yesterday something about Jordan, and it gave me the wrong answer because it just thought I liked this answer. So, clinical decision maker, this is back to what Ahmed was talking about. It's been explored in AI-powered applications for decision-making in gynae-oncology. And the summary of this paper is that it was able to come up with quite coherent therapeutic recommendations. If you were here for the talk yesterday, I mean, on cervical cancer, it was mind-boggling, the different therapies, even the FIGO staging is now beyond my brain to comprehend. As a non-gynae-oncologist, it used to be FIGO staging was 1, 2, 3, and 4. It's got very complicated. So ChatGPT and these AI models can actually give it. And I say, the conclusion in the paper was that it processes complex patients very well. It gives solutions, and it can be very well integrated into medicine. And the future is here. But let's get back to the practical, into the operating theatre. Yes, it can be used for scheduling. My theatre list was always scheduled by my secretary, who knew roughly how long I took to do procedures and where to put the patients. That all could be automated because we don't have secretaries anymore. I like this, though, when it comes to instruments, and there are now models on the market where they use a computer to monitor the way you're moving in theatre. Okay? They can actually count the swabs. It can actually count your instruments. And it can actually prevent delays by making sure, we've all been there. You ask for a particular instrument or suture and they say, it's not back from sterilization, or we've ran out of those. So it helps with all of that stock taking. Obviously, training using simulated VR models can be very, very effective. And for rehearsal, particularly if you think of some of the gynae-oncology and gynae-endometriosis we saw yesterday, where you're not really sure what you're going to do, but you can rehearse it. It's now been used in neurosurgery, cardiothoracic surgery. What is the best approach to this tumor? If I go to the left, if I go to the right, practice different ways so that you can actually decide. And then you involve that in the consent. This is the way I've practiced, Mrs. Jones. This is the way I think will work for you. We're going to try it here, okay? But I say, AI is here. It's everywhere now. And I'm going to talk a little bit about my new car. I'm very excited. I got a new car 2 weeks ago. It overtakes the SpaceX. AI is now worth, the OpenAI is now worth 500 billion. And those of you who read the paper yesterday, NVIDIA, who make the chips, is the first company in the world to be valued at $5 trillion. It's a really, really hard figure to get around your head. Apple is about 3 to 4. I think Microsoft's about 3 to 4. And this is now, NVIDIA has just taken over this. So my new car is brilliant because in daily use, this car will park itself. And it will unpark itself because it remembers the way I got into a difficult space. And it will park in complicated ones, which are diagonal. Okay? And everything is now, I mean, my car not just does the park assist, it changes lanes if I want. I'm happy enough to change lane myself, but if you want to, it will change that. And I say it's remarkable what is now just totally built into the, we always use in medicine the airline industry, but the automotive industry is racing ahead here. And cars have everything, GPS, and the AI part of it here. There's some of them, automated parking, collision avoidance, amazing. Lane assistance, artificial intelligence on your navigation and your speed control, everything is there. Can we then put that into the OR? I think it will come. Of course it will. Collision avoidance, avoiding a nerve or a vessel, because it knows, your robot knows where those vessels are from the imaging pre-op. Automatic knots, we were talking yesterday. Knot tying eludes a lot of people. That's why we use, barbed sutures. But actually, you just will press a button or a pedal on your robot and it will tie the knot. It's an automated process. Very, very easy. Those of us who still don't have robots, we have an assistant holding our camera, and they get tired and they're not sure what to do. That cameras can be remotely controlled very easily. Speed control, I'm not so sure. Will it kind of make it go faster or make it go slower? What's the optimum time for an operation? But it's interesting, this morning, the very first talk I listened to was about your study on ventral suspension, lateral ventral suspension, and some of the surgery took 4 hours and some took 1 hour, so maybe speed is needed. But I like the blind spot. The cars now will detect that there's somebody about to overtake you in your blind spot. And the same, what we always got problems with diathermy being activated out of your field of vision. That will be very, very simply dealt with. If your probe isn't visible on the screen, it cannot be activated. Brilliant. Tiredness. The car alerts me if my head starts to nod. Okay? And it will pick up those subtle things which hopefully your assistant might notice, but we've all had assistants fall asleep in theatre. Okay, so I'm just going to move on a little bit. We've got a few minutes left. So the sensors I've mentioned, the algorithms, the processing, and these are all examples. There's now an augmented surgical suite which overlies the 3D anatomy in your goggles, so you can, or on your screen, so you can see. So you get pictures like this, particularly for neurosurgery, where they can actually see the imaging in their field of view operating, which is remarkable. I'm going to stick with the intraoperative AI. So robotic surgery, we've heard about tremor reduction yesterday as well. You're going to get 3D visualization. It's a bit like 3D ultrasound. I'm okay, but some people do need a 3D image. It depends how dyslexic you are, I suppose. But the real-time guidance I'm fascinated by, and also alerting surgeons to potential issues. Workflow optimization, again, will be amazing, because we will be working in a field where the computer is watching us, as I say. It will tell us what we're doing right and wrong, swab counts, etc. So will there be a robot like this replacing our anaesthetists? I don't think so, but anaesthetists love their tech, don't they? So they're already using it, because it can monitor subtle changes in patients' observations. It can be personalized, looking at the various drugs that the patient's on, the various drugs the anaesthetist is using, patient's weight, etc. Totally tailored. So it's no longer you trying to work out the drugs on the back of an envelope with a pen and paper, or even with your iPhone. Regional anesthesia, again, that's just guiding you to the nerve properly. And again, automated tasks which will help patients. Post-op, the automated tasks are really interesting, because some of you may already do this, but automated notes and automated post-op instructions will be very, very easy. It will produce a draft for you, and you make minor adjustments to it. So it's going to speed up not just the time, but the mistakes will not be there. There's evidence 24% less discrepancies. Similarly, post-op instructions, monitoring will be, again, the same as the anaesthetist during surgery, watching these subtle trends. Again, think of the woman who is slowly bleeding post-op, and her heart rate slowly rising, and no one has picked it up. We do it manually using Muse charts, and we're plotting to see, are there any ambers or any reds? But I think AI will take over this. It's very, very simple. Pathology, it's already there. We use it in cytology and in radiology. And I think back to the consent, personalizing your rehabilitation. I have a friend who recently had knee surgery, and it's very different having knee surgery when you're 63 or you're an athlete at 33. And it needs to personalize that. And it will be very, very easy to say, here is a personalized rehab plan for you. But of course, those of you are here, I'm probably preaching the converted, you're all AI converts. Those who aren't here are fed up. But it's expensive, but it will come down, like everything. It requires deep technical expertise from the manufacturers, but not at the drive. I don't know how my car parks itself. I don't need to know. I just press a button to say park. And that's what will happen. The concerns, I'm not concerned about them really. It's, we're already giving away our data. The privacy, you just have to be very careful. Cybersecurity, deceptive content, bias, conspiracy theories, you name it. We all have to be aware of deep fakes. I'm not sure how it will impact on AI in medicine. I think we will have very secure systems. Patient data is very careful. I would encourage you to take a picture of this. I put the QR code there for you. This was a really good discussion from Harvard this week. I listened to it, talking about building effective AI into healthcare. Harvard's Children's Hospital is totally, we're talking decades ahead of the rest of the world. And I've just summarized there, but please go and visit that. It's about 20, 30 minutes. And they're using AI Copilot everywhere. They're using the tools for research, admin, and clinical decision-making. They're curating their data, and they're now asking the questions. If there's a problem, ethically and perhaps from a governance point of view, whose fault is it? Is it the manufacturer of the AI, or is it now, if I park my car and push the park button and it crashes, it's my fault? Is it? But if I've trusted, I mean, we've heard of Teslas crashing, driving into people and stuff, you know. So the AI, those are minor concerns, but we don't know where it's going to go. But it is getting better. We have moved, this is one slide which summarizes where we've gone from smartphones through social media all the way. I mean, it's standard now in your bank. You will get fraud checks if you do something unusual. If I try and buy something today in Jordan with my credit card, it will flash up. Why is he suddenly in Jordan? He's not usually there, okay? And we take that for granted. The vehicles are there, and smart homes. I have smart lights, that's all, and smart heating. I'm going to finish because I'd love to hear what people's thoughts are, but I like to say to everybody, we all hated self-checkouts when they came in, you know, in the supermarket, and they didn't work. They now work brilliantly, and I again will always go to the self-checkout. Bing, 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 check out my 3 products, put them into my bag and walk out. Amazon shops, you don't even have to do that. You walk out, they've already scanned your face, and they know who you are, and they know what you picked up. So it is really, really incredible. So self-checkout is here. So promise or peril, chat or cheat, friend or foe. My take-home message is AI is not going to replace physicians, but the physicians like you and I who use AI, okay, will replace the physicians who don't. Okay, and our patients want us to use AI, and our patients will use it. So thank you very much. I'm going to go and get myself washed off of the mud, and I'm happy to take any questions that ChatGPT can't answer. Okay?
Thank you. Thank you very much, Paul. Do we have any questions from the audience? Everybody's happy with AI. Okay, my friend. Thank you very much.
It's a glimpse of the future. Let's talk about it in 5 years, okay? For sure.
Thank you very much. Shukran. Okay, may I ask Rani, Kate, and Hassan to come to the podium now, please, for the IRC chair handover ceremony, please. يلا تفضلوا.
Professor Hassan, Bismillah ar-Rahman ar-Rahim. So actually we wanted to use this important occasion today because, please have a seat everyone, thank you. This is an important occasion for us as an RCOG because this day today will mark the handover
of the chairmanship of the RCOG Jordanian committee presidency of Dr. Professor Mazen Zibda, who will be handing over to Dr. Ayman Rismaida. But before we go into the ceremony, I would like to say a few words about both of them. I'll start with Mazen. Apart from, I will be mentioning him in my last lecture today about recurrent miscarriages, because he has published a lot in that field, and the world literature is very grateful for him. Mazen has always been a very good supporter of the RCOG. He has represented us extremely well, not only in Jordan, but also in the whole of the Arab world. And Jordan has always been at the forefront of the IRCs that we're very proud of to have collaborations, and we always use the Jordanian IRC as a benchmark for how the work should be done. And I think before him, there has been fantastic chairs, but it is really my pleasure to thank Mazen. Thank you. Now, thank you. Mazen not only represented Jordan, but also in the difficulties of war, he has also represented Palestine and Syria. And the work the RCOG has done over the years with the IRC, as well as the British Jordanian Society, and the Obs and Gynae Society has been remarkable in supporting our friends in Syria, but most importantly in Palestine in very difficult times, where we have delivered courses such as the also and all the maternity emergency courses. And Mazen and the committee has been great. Now, Mazen doesn't do this on his own. He is supported by a fantastic team of his committee members. And they're all, I know some of them are here, some are not, but over the years, they have dedicated their time and effort. And remember everyone, these jobs are voluntary. Nobody gets paid for it. And therefore, we must really appreciate. And so Mazen, it's my honor and pleasure to have worked with you over the last years. And it's coincidental we're leaving around the same time, few weeks difference between us. Now, Mazen will be handing over to a very good friend of mine. And actually, my first contact with Jordan was through Ayman. When he emailed me long time ago, introducing Dr. Amir Gharaiba, who at the time wanted to come and do some maternal medicine training in the UK. I didn't know him, he didn't know me, he just came back from Norwich, and then the rest is history. His son now works with us, and the relationship has become more of a family and friends. And I know Ayman, with his background in the Jordanian society, Fil Naqaba, and a lot of all his political background and connections internationally and nationally, he will do a fantastic job delivering our IRC KPIs. But it's very important also to acknowledge the other two candidates who have applied for the job, who were unsuccessful this time, but they come with a plethora of expertise and experience. It was a very difficult decision to make, but we're also grateful that people have applied for this job and hopefully will continue the work. And I would love to see you work very closely with Kate, the new president, and Sharif Abdel Fattah, who will be taking over from me. So I will introduce now Kate.
Thank you, Hassan. So I first met Dr. Mazen when I joined the college in 2019, and he's been a source of inspiration and advice for me since then. I have to say, as members of the RCOG, he has represented you very well. The bi-monthly meetings that we have with Dr. Mazen have been an absolute highlight over the previous years, and we will be very sad to say goodbye. And I don't think it'll be goodbye. I'm sure we'll continue to see you as you come out here. And I remember in 2022 saying to me, you really must come to a meeting in Jordan. And so I'm delighted that I was able to do that while you remain as IRC chair. You've pushed us hard, you've challenged us when it was the right thing to do, and when we weren't doing the things that you thought we ought to. You've challenged us, but you've also supported us hugely over this period, and we're enormously grateful for everything that you have done, both for Jordan and obviously Palestine and Syria, but also for the college. You've been an absolutely wonderful ambassador for the RCOG in the Middle East, not just in Jordan, and we're hugely grateful for that. I hope the next chapter is just as successful for you, and I'm really hoping that you stay in touch with the college over that time. Thank you so much.
First of all, I would like to thank Professor Rani Thacker, Professor Hassan, and Kate for coming here and sharing with us our meeting. I know I started in September 2019 as the chairman of the IRC in Jordan, Palestine, and Syria. Unfortunately, when we started, everything was going down because of the corona. So we didn't have much activities for nearly 1.5 years. But we managed to do some activities online. And we have 2 or 3 congresses. It was online, and it was connected with other colleagues in the MENA region, not only for Jordan. And the lecturers were from UK, from the United States, and from Europe. And we kept contacts with other MENA region IRCs in Egypt mainly, in Iraq, in Kuwait, and in Saudi Arabia. One thing is important, which I feel we have done in the last 5 years. Before the 2019, we are the 3 groups in Jordan: the British Society, the Jordan Society of Observation, and the IRC. And there was some sort of competition between the 3, and everyone wants to do his own activity. So when I started, I said, we should not do this, because we are one body. We are only the active people who work in Amman and interested in research and lectures and meetings, 300 or 400. So it will not be ideal for us as members of the college, around 70 or 80 at that time, to have our own entity, and the OBGYN, they have their own activities, and the same for the British. So we said, let us start work together. And this is the second collaborative congress between the 3. By this way, we attracted more audience to attend, and we got more support from the sponsors. And we kept our good relations together. So this is very important, I felt, which we achieved in the last 6 years. The second thing, I think I myself tried, together with Kate and Professor Rani and Professor Hassan, to keep the collaboration with the college. I think in the last 6 years, I signed 2 contracts for the collaborative framework. Through this collaborative framework, we managed to keep contacts. We managed to do the MPI, Medical Training Initiative, and we managed to have around 10 or 12 doctors to go and continue their training in UK. And I hope with my friend Dr. Ayman, this will continue and may have larger number of doctors to go to UK and proceed to get their MRCOGs or to go even for subspecialty training. So thank you, Professor Rani, thank you, Professor Hassan, and thank you again to Kate, and my sincere thanks to my colleagues from Jordan and to all of you. And wish Dr. Ayman Smadi a very successful and good time when you become the president. Thank you.
But we now have Dr. Ayman Smadi. Mazen, thank you very much.
Thank you very much. My thanks goes first to my colleagues in Jordan who supported me and encouraged me to apply for this job. And second, for the college who entrusted me in this post. I hope I will be up to this post, and it will be difficult to compete with Mazen. Mazen did a great job. Hopefully I will continue with their advice. Our senior colleagues in Jordan, our colleagues in Jordan who can help and can support and advise. I don't want to talk for a long time because it's time for break, but thank you very much. Thank you for this opportunity so we can handle the responsibility from a great mentor and a great friend and great brother, Mazen, to me. And thank you, Hassan, for your support. Thank you, Rani. You have been a great president, and I hope you continue your support for our society from outside the college. And Kate, I'm looking forward to work with you for the best of our IRC and best of our college. Thank you very much. Thank you.
Now, can I ask Madam President to come?
I have to start by warning you, Eamon, you have a very, very hard act to follow. Dr. Mazen, you have been absolutely amazing. I've known you since I was vice president, when you used to keep coming to me saying, Rani, we got to do exams, we've got to do teaching. And what an amazing role model you have been. Your teacher, I know that you are determined to teach, you are passionate about teaching, and what better thing can you do but restore the future of our doctors. And it's not only in Jordan, but you've been so generous with your teaching and training with Palestinians, Syrians, and I'd really like to thank you from the bottom of my heart for that. I'm sure you're not gone, you're going to be around. And I still continue to look forward to seeing you. Like I said earlier, Jordan is like a second home. And yesterday you offered me a passport, so thank you very much. Yeah. On another note, it's my great pleasure to also say goodbye to Dr. Aber, who is finishing her term as the president of the Jordanian Society of Obstetrics and Gynecology. Aber has become a very good friend, and I can also warn you that when you see a little woman with a white suit, you should be very, very careful. By the way, we didn't plan to wear white, but we are wearing white. But when I think of Aber, I think of intelligence, I think of elegance, and I think of dedication. And in that little body, she's always challenging you. And I saw that today. If there's no question, Aber will ask a question. Besides her contribution to women and girls, I think she's done a lot more for this specialty, not only over here. She's ensured that you have remained a member of FIGO. And when I was chatting to her, I was saying, well, what are you going to do after this? She has no plans to rest. She's going to continue the next stage of her life, which is about serving women, especially in the menopause. She's planning to do lots of charity work. And Aber, I hope our friendship continues. Thank you very much. And because she's such a wonderful woman, and because we have such high regard for her from the RCOG, we have actually honored her with the honorary fellowship of the RCOG. So let's give her a big hand, a very, very well-deserved big hand. Thank you very much.
Okay, can we have a quick coffee break now, and then we'll come back for the last session. Thank you.
Good afternoon, everyone. And it's my pleasure to welcome to this debate. The title of this debate, as you see, Rising Caesarean Section Rates Is it alarming or justified? And I found that to have three big distinguished speakers and figures and very experienced consultants and professors to discuss this subject, so I invited Professor Rani Thacker and Professor Paul Fogarty and Professor Yasser Abu Talib to share with us this debate. As you know, cesarean section is becoming an epidemic. And it's not only in the Middle East, it's all around the world. Maybe if you look at the statistics, which is coming from Latin America, it's nearly 70 or 80%. And I understand from my colleagues from Egypt, it is nearly 55 to 60% of all births. In Jordan, the reports which came from the national group who studies maternal mortality, which I'm a member of this committee, and my colleagues here, many of them here, the cesarean section rate in Jordan is nearly 27%, and I think in the last year it was 31%, so it is rising. If we look into United Kingdom, I think the last report came around 32% of all their births, while 2 years ago it was 27%. So it's rising everywhere in the world. So C-section is a major surgical procedure, we know, and it's the most common surgery done all around the world. And we know when it is done for medical reason, it is life-saving for both the mother and the baby. But when it is not done, when it's done for no indication, there is a lot of reports say that there will be some morbidity or mortality to the babies and the mother. C-section are increasing globally. Around 30 million babies are born by C-sections each year, according to WHO report 2023. And C-section is 21% expected to reach 30% by the year 2030. So is there an optimum cesarean section rate? Or just everyone will explain the rate according to their own circumstances, according to the regions even, and even to the hospital differences, like what we see, for example, in Jordan. Some hospitals have 20%, other places they have 40 or 50%. So in December 2021, the WHO recommended rate not to exceed 15% of live births. However, according to WHO examining the relationship between CS rate and maternal mortality in 194 countries, calculated that CS rate up to 15% is associated with decline in maternal and neonatal morbidities. So that's the figure which was given by the WHO. But is that figure the same everywhere in the world, or just a theory? I think we will find out what. Research examining the relationship between cesarean section and maternal mortality in the 194 countries concluded that C-section rate more than 19% showed no improvement in maternal and fetal morbidity and mortality. So the WHO recommended rate not to be more than 15%. So after this introduction, I will welcome my colleagues here and our distinguished professors to have their opinion about, is this rate possible, and can we do something to reduce it? And before we talk about can we reduce it, we want to see why the rate has increased. May I ask Professor Rani Thacker for this question?
So I think the general understanding in the UK right now is that we shouldn't have a optimal rate, or we shouldn't say that there is a particular percentage, because we have had incidences where when you set that target and people are aiming for that target, they actually forget everything else around that. They only look at the number. And do not look at the mother and the fetus, and we have had instances where we have had bad outcomes. I think what is important is to find out what the woman wants, why she wants what the mode of delivery that she's choosing, and trying to understand what it is. I think it's a joint decision. It's not up to us to decide, but it's about deciding what is good for her, communicating that with the patient or the woman in front of you, and maybe with her partner as well, and trying to come to consensus as to what is best for her. So I do not think it is right to set an optimal rate. I see that WHO has done that, and I think that's a mistake, personally.
Okay. Any comment from our panelist, Professor Fogarty, please?
I echo everything you've just said, Rani, and WHO have produced 15%. The genie's out of the bottle. We will never be at 15%, I'm afraid. And getting the only place that has 15% is parts of Africa, and the big pressure there is because people can't get cesarean section, they're ending up with fistulas. So somewhere, this around 30% to 40% is fairly standard. The unnecessary cesarean sections is what we need to focus on. Perhaps it's very hard to justify 80% and 90%, which parts of the world are having, and there's lots of drivers for that. Can everyone see the slide you have? But I think what we need to focus on, and the rest will fall out of this, is if we can reduce it's number 3 there, increasing rate of primary cesarean section. Why is people having their first cesarean section? Would be my big question. I don't, and get that. Let's see what that percentage is. You're familiar with the Robson criteria?
Yeah.
My colleague from Dublin.
Robson.
So the Robson 1 to 4 are people having a first cesarean section. Normal baby, vertex at term. Why is that baby having a cesarean section? That's a much better figure to compare.
Yeah. Okay. Professor Yasser.
Okay. So I think the situation back in Egypt is completely different. We are overrated cesarean section. You know that we are coming in the arrangement of birth rate after Dominique in the first, second Brazil, then Turkey. We are in the 4th place. The cesarean section rate climbed up just sky high, and it's now nearly between 60 and 70%. But to be honest, I try to analyze, because I'm one of the group, try to trace the cause of that. The point that they are collecting all cesarean section, but as Paul said, I think one of the most important things to separate the primary section from other types of section. But to be honest, I don't think that we can achieve what you said within maybe 10 years. Just to make the cesarean section rate dropping to 30%, it's very difficult actually. And as Paul said, and Rani said as well, we have different causes. There are unexplained cause of marked increased cesarean section rate. Maternal requests become a common, and even because of the medical legal problems back in Egypt and everywhere as well, everyone tried just to come over the problem that might occur during normal labor by cesarean section, and he doesn't know that the mortality from cesarean section after the Royal College, it's 1 in 4,000. Meanwhile, in vaginal delivery, 1 in 25,000. So it's different completely.
Okay, thank you. I agree with you. There is a lot of debate on the rates, and a lot of authorities, they don't take what the WHO has said. Professor Fogarty mentioned that the primary cesarean section, we have to concentrate on this issue. I think we are going to discuss it later. But I think in this slide, which shows why women having cesarean section now. We know that for medical reasons, women are becoming obese. They are getting pregnancy at an elderly age. And I'm not blaming the monitoring during pregnancy and labor, because a lot of papers said if you monitor the woman during labor by continuous CTG, that makes you more nervous for any changes, and you may opt for cesarean section quickly. The other things is increasing rate of labor induction, and which is becoming a practice in our region here. I'm not sure what is the situation in Europe or in the United States and the UK. A matter of convenience. I think we all look for to work in a proper time. For me, I like to have my patient delivered during the daytime, and I don't want her to call me during the weekend. And the woman is the same. She wants her husband to be off work so he can bring her to hospital and he stay with her. But the convenience for both mother, family, and the obstetricians. Concern about malpractice, which is becoming common now, not only in Jordan. I think we are inheriting it from the United States, because a lot of patients and a lot of people look into the net and on the media, and they say how this patient had a problem and she was in labor for 10 hours, then she had a baby, suffering from birth asphyxia. So they want to catch anything to blame the doctor, so the doctor escape from the medical legal litigation. I think the safest for me is to get this patient out delivered by cesarean section. The other point, which is increasing now all around the world, cesarean section on demand. And I think we want to discuss this. I think there is a lot of guidelines which say if women ask for cesarean section, it's not a straightforward answer to say, okay, yes, go for cesarean section. And what do you think, Professor Thacker, regarding this matter?
So I run, as I said this morning, a perineal clinic where I see women who have had birth in the past, and sometimes we make plans for the future pregnancy and birth, and we discuss with them, and many of them will say, I want to have a cesarean section because of the experience or because I'm afraid of what is going to happen. And this now, because there's so much in social media, TikTok, Instagram, with people telling the horror stories even before they've given birth, that people have decided that giving birth will actually be bad for them. It will be a bad experience. It will affect their pelvic floor. It will affect their sex life. So the way I deal with this on practical terms is I sit in front of them, I take time, I try and understand what the problem is. I tell them about the pros and cons of both vaginal delivery and cesarean section. It's out there on the website. But the other thing I tell them is if you have one cesarean section, you're going to have multiple cesarean sections. And the more cesarean sections you have, the more complications you're going to end up having. And I have to say that once you tell them the pros and cons, once you then also convince them that they will receive good care, you will ensure that they have got a midwife who will look after them, the same person who will look after them, they quite often will change their mind. So I don't think we can say that women, it's on demand or maternal request. There is a reason for it, and it's our job to try and find out what that reason is.
Okay, thank you.
And that means spending time with patients.
Professor Fogarty, do you have any comment on this subject?
I could speak for the next 26 minutes. Rani's last statement was you need time, which we don't have at busy clinics. So to try and go through the pros and cons and talk someone into even a VBAC or a normal delivery might take you 30 minutes, might take you 45 minutes, and there are 50 patients waiting outside. So it's much easier to say, what date do you want? I'll book you in. So there's a systems error there, the systems fault. And the way around that, which we can do, is that most of our normal patients are seen by midwives. So they don't get to make a decision to do a cesarean section, but they've got more time to talk about it and reassure the patient. But it's very difficult. Sorry, I wasn't texting there. I was actually just looking up there. Has anyone been successfully sued for an unnecessary cesarean section? And the answer is yes. 1.5 million in America. So that's the future as well. You know, with this fear of litigation, we're going to get a little bit, the pendulum will swing back where people will start saying, wait a minute, I had a cesarean section and I ended up with a hysterectomy, or because it wasn't medically indicated. So that I've moved on a little bit, but coming back to patient request cesarean section is actually a very small number in the UK. It's not that many people, unless they've had a previous problem, but a first pregnancy, unless they have an extreme tocophobia, which you can manage with psychological treatment, then yes, you know, we don't get a huge number. Most people are happy to try a physiological process, but we do focus on these ones that are maybe the outliers.
Can I just clarify that when I'm talking to them, I'm not convincing them to have a mode of delivery, so vaginal delivery or VBAC. I'm convincing them to have the thing that's right for them, and then they choose. And it may be a cesarean section at the end of the day. If after I've spoken to them, after I've counseled them, they still want to have that, then I think we have to support them.
I agree. Professor Yasser, do you think?
Okay. The situation is different again. So we try to dig in the causes of that problem. And maternal request for cesarean section. And we found that the main cause by root cause analysis is she is afraid. And the doctor as well, that he's going to deliver her is afraid. And when we analyze the cause of this problem, we found that she is afraid of pain. She's afraid of being alone for the mother. And for the doctor, he's afraid because he is busy all the time, cannot follow up the cases strictly. And he is afraid of fetal distress during the first stage of labor, second stage of labor, and he thinks that postpartum hemorrhage might be managed if we have vaginal delivery better than that. That's why we start to have some sort of modification in our policy. But this is the main cause, just counseling.
Yeah, thank you.
The lady is very important because of pain, and let her to know that her husband will be with her.
Okay, thank you. This comes when we counsel patient for VBAC, or if maybe it will be easier, because if she had bad experience in the previous cesarean section, like what we see here in Jordan, she labors for till 20 hours and then ending in cesarean section. She said, okay, just let me have cesarean section straightforward. I don't want to have to suffer like what I suffered in the past. So it's multi-factors, not only the patient's own experience, plus her fear, the effect of the media, and maybe her mother or sister experience. They always say, oh, my sister, she spent so and so, and she had very bad delivery. Also, there is some influence of the media regarding the topic which Professor Thacker mentioned this morning. What's the effect? She is afraid of the side effects or the consequences of vaginal birth on her pelvic floor and her future sexual function. So I think a lot of women now, they come and tell us, is it safe? Yes, safe. But will it affect my future sexual life? I think we have to have evidence-based answer to these women. Because if we just answer out without putting statistics and figures and say to her, this is the percentage of incontinence of urine, this is the percentage of women who need to be counseled for sexual dysfunction, rather than saying, okay, yes or no. I have no answer, yes or no, but I have statistics and evidence-based figures to show these women and her partner or her husband, then it's up to them at the end to be convinced or not. But I agree with you and Professor Thacker that if they insist on vaginal birth, on cesarean section, we cannot stop them. We have to respect women's autonomy. She wants that, okay, you will have it, but after I consume all my armaments and trying to convince her on evidence-based. And if she has insisted on cesarean section, okay, go for cesarean section. I can't deny her her wish to have cesarean section.
But the situation for VBAC is different.
Yeah, it's different. I'm talking mainly on primary. So I just put these little figures here. In UK, women who gave birth by C-section were 5 times more likely to die than women who delivered vaginally. And this came in November 22 in BMJ Global Health. A mortality rate for women delivered by C-section was 3 per 1,000 cesarean section. Risk of death is more than 5 times that for women delivered vaginally. It's frightening if I just put these figures in front of patients and my colleagues. More than 25% of maternal mortal death occur in women underwent cesarean section. And this point, the last statement, it is argued by many obstetricians because if I'm doing cesarean section, it doesn't mean the complication only related to cesarean section. If I'm doing cesarean section for severe preeclampsia or for PAS syndrome, there's underlying cause which made the cesarean section added to the risk, but the main risk is what brought her to cesarean section, not cesarean section itself. So
but with respect, we're comparing apples and oranges because there's a world of difference between elective cesarean section, planned spinal anesthetic, done nice and calmly at 9 o'clock on a Monday morning with a consultant, specialist, consultant anaesthetist, and a crash section at 2 a.m. by 2 trainees. You know, and we can't compare the two. They're like totally different animals, yeah? And I think that figure of 3.1 is including emergencies.
Yes.
No, that includes all cesarean sections.
All cesareans.
What is the risk of women having a planned elective cesarean section?
I can't remember the
first
figure,
pregnancy,
but it is much less than
it's
the
virtually the
emergency.
same.
Yeah, it's less than the emergency.
Yeah.
So, after this discussion, and it talks about rise, because everyone in the world took a cesarean section is going high. Can the rise of cesarean section deliveries be reversed or reduced? I'm not saying brought down to 15% or 20%, like what the WHO recommends. But like for Egypt, Professor Yasser, you have the highest figure in the Middle East.
That's fine, definitely. We start to have our plan to reduce cesarean section rate. And I think Kate was with us and I had presentation last year. We started actually to do that. First of all, counseling. It's very important to convince the lady that everything will go right without pain and with her company for the mother and the husband as well. That's number one. For the doctor, it's very important to save the midwifery system that we are going to push it forward just to be sit with the lady all the time. Number two, and we start actually to apply that. Number two, preparing the doctor by giving him special training for monitor using partogram, which is very important, and physiological CTG. Physiological CTG, which is different from the normal CTG. The most important thing that we try to push forward, it's get back to, in Egypt, to an instrumental delivery, which is markedly deficient there. If we are successful to do these points, I think we will be successful in doing that. And we started through the committee of the Royal College to have a special training for all of these things: counseling, partogram, CTG, and instrumental delivery as well. And I think it's working. But
thank you.
What's new, what's upsetting me, that the government just raised a very important issue that I told the minister that it will be difficult to apply that. They came with a law that it's forbidden to do cesarean section. I don't know how it did that.
That's impossible.
They are going to evaluate.
We don't want the politician to interfere with our work.
They are going to evaluate
every
case, even in the private sector, to see if she has cesarean section or not. I don't think it's work.
So I would agree with actually improving the training of assisted vaginal birth, both ventouse and forceps, ensuring the right method is used, for the right circumstances, you've got to also bear in mind, I would say that, the pelvic floor, if you're using forceps, but not to say that you should throw it away. It's about educating women, empowering women, so that they know the pros and cons, as I said earlier. And because when we have done research and spoken to women about perineal trauma, and in other areas as well, mothers have actually said to us that they would rather know what can happen after vaginal birth. Even if it's perineal trauma, they would still choose to have a vaginal birth, but they just want to be known. So I think empowering women is really important. So providing them information in a way that they understand, which does not necessarily mean an information leaflet on paper. People don't read those. So we need to start thinking outside the box. And providing them information in a way, be it TikTok, Instagram, whatever, because we are very good at making information leaflets, which are not necessarily used. And then the other thing is to try and make vaginal delivery safer, so women opt to have a vaginal birth. I think that's what we need to be focusing on.
Yeah, I agree with you. I remember, Professor Yasser, when we were in Cairo last year, you mentioned, or you have a debate on the role of the trained midwife. And I think there's a lot of United States centers, they concentrate on training and educating midwife how to look after the laboring ladies. And they found that a trained midwife associated with reduction of the cesarean section rate, beside the reducing the extensive monitoring to like continuous fetal heart monitoring to the high-risk women, and not as a routine for all women. I think because of the time, in the next 5 minutes, I will show what are the stands of different scientific authorities. So what's the FIGO? FIGO has different view from the Royal College. FIGO acknowledges that rising C-section rate are global concern, particularly for medically unnecessary procedures, as they are linked to increased risk of both mother and babies. The FIGO stance is that while all women who need C-section should have access to one, so there is no denial for their wish, the overall rise must be stopped. The organization advocates for a multi-pronged approach involved joint action from medical professionals, governments, and public care, unnecessary C-section, and promote informed decision-making. So this is their opinion. I think it goes with what you have suggested. You know, we cannot deny women who ask for it. You have to discuss and use evidence-based medicine and counseling of these women.
This is the problem of FIGO and other organization.
Yeah.
So as if we are in the House of Parliament or something like that. So it will be just broad words, but I would like to have it in implementing points. How can we do that? Because just to tell me that we have to do, and the government must. So I think it's very important. It's time to have a guideline like the college. We are going to do so. We are going to do so. We are going to do so, instead of just have a general information without target things.
I agree with you, because they are more or less towards the WHO recommendations rather than the RCOG. But I think here in the red line, the strategies, FIGO strategies include raising awareness among both doctors and patients about the negative aspects of cesarean section and the benefit of alternatives like vaginal birth after cesarean section. So you have, it's through the other points: education, practice, experience, and counseling.
So if I'm going to tell education, that's fine. Thank you very much. I'm going to educate them. Educate them what? And how? Because we have 3 or 4 levels of education. So I don't think that we are going to educate this, like this, like this. So at the end of the day, it will end by doing nothing.
Okay, I agree with you, because if you are looking after not middle class, lower class people, or less educated, or communities of low economic standard, I'm sure they have a lot of complications.
I'm sorry to disagree, but we cannot blame the patient's IQ for a cesarean section rate of 80%.
IQ, but the standards of
We need to educate our
generally.
midwives and doctors, probably much more importantly. Not the patient's problem. I'm sorry. If a patient comes to you and says, what do you think I should do? And you say, have a cesarean section, they're going to say yes. You know, they trust you. They come to you.
That's why we start to change the idea of midwifery system. Because midwife back in Egypt used to be ignorant. She's delivering a lady, getting money, go back home, and that's it. Now, midwifery system will rely upon educated midwife, graduated from the faculty of nursing, which is 5 years education, with subspecialty in delivery. That's the new thing that we are going to push them towards being obstetrician supporters, not the classic one. So education for whom? For the midwives, not for the patient, because how can you educate them?
Okay. What about, and this slide shows the American College stance on cesarean section. I think the last paragraph, the official position focuses on safety, safely reducing the rate of primary or first-time cesarean section, which is the most effective way to lower the overall rate. I think Professor Fogarty mentioned that primary cesarean section, if we concentrate on reducing this rate, because if a woman had 1 cesarean, maybe she will have more and more cesarean sections. So RCOG promotes evidence-based strategies to support vaginal birth and manage labor. So I'm not going through this because it's repetition. And look at the RCOG, and I think Professor Thacker has mentioned it, and I remember when I was reviewing the stance of the Royal College, I remember, I think a few weeks ago you mentioned something about this. So the Royal College of Obstetricians acknowledges the rising rate of cesarean section, but does not promote one mode of birth over another. So it kept the door open. So every method is safe, but there are conditions. Its position focuses on supporting informed decision, ensuring adequate resources for care, and addressing the underlying reason for the increase. So I think, do anyone of you, as
the same issue is there's no implementation in this. Maybe that's your next slide, though. I don't know what your next,
Go to the other slide.
How do we implement that? Here we go.
Yeah.
Because WHO has got a really nice implementation.
So the RCOG said neutral stance. The RCOG does not advocate for or against any particular mode of birth. Instead, it supports women making an informed decision about their delivering method after discussing the risks and benefits of both vaginal and cesarean birth with healthcare professionals. So proper counseling and discussion. And at the end, they want to make decision. It's up to them. Understanding their eyes and focus on the quality of resources, which is very important. Because if we do cesarean section in bad resources, and they say maternal mortality is high, it's not because cesarean, because you are working in an optimal situation. But if all hospitals and centers are provided with excellent facilities, excellent anesthetists, they have epidural anesthesia, and they have senior staff to back up the junior doctors who may be doing the cesarean. So the mortality rate, which most centers say, cesarean section increases mortality rate. It doesn't increase, in my opinion, if the facility and the center is high class. But if you work in deprived area and do cesarean section, the mother will die, And they said she died from cesarean. She died from lack of facilities and lack of training people, lack of a blood transfusion facility, and it is not highly trained. So these factors will add to the risk and increase the maternal mortality. And lastly, I will go to Jordan, what we have done in Jordan. Since the year 2016, we started to study the maternal mortality. Dr. Maher involved, Dr. Abir, Dr. Raibe. So we had Dr. Fakher and Dr. Abdelmane. So a committee formed from all centers in Jordan, the universities, public sector, Royal Medical Services, and the Ministry of Health. So we studied the maternal mortality reports, and from this report, we extracted a guidelines for the Jordanians. And we found that around 52% of women who died, they had cesarean section. So some people say, they died from cesarean, so let us stop cesarean or reduce. But when we analyzed, we found these 52 women, 52%, who died from cesarean. It's not the cesarean which killed them. There are a lot of factors which killed them. Women transported from the periphery to a central hospital, and in the central hospital, they did emergency cesarean because she lost 2-3 liters from placenta previa. So she didn't die from the cesarean, she died from the blood loss. So that's why the figures which came out from the maternal mortality report, not accurate regarding the cesarean section and mortality rate in women. The same for ShareNet, which is another NGO in Jordan, which works on health and mortality. And I think we extracted, and I was involved in this report as well, a delay in labor progress. We put the guidelines. We said, if we, as Professor Fogarty mentioned, the delivery ward, if you have a proper monitoring in labor and the trained staff and facilities, so you will not rush for any simple change in fetal heart and say fetal distress and take for cesarean. So number one is the proper monitoring of the fetal heart.
How do you define proper monitoring?
And the
I mean,
mother's
we're not talking about electronic monitoring? Are we talking about intermittent auscultation?
Yeah.
Okay.
So it's multi-factors, monitoring whether it is interrupted or electronic, or even midwife to use the Doppler. But you have to have someone who analyzes the findings and not rushing for saying, oh, this is type 2 deceleration is a very bad fetal heart. And if we apply the nice guideline regarding the fetal heart, I'm sure we will reduce the number of cesarean section for unnecessarily fetal distress. The second point, I think in Jordan, we concentrated on monitoring labor and the progressive labor. We adopted that first stage of labor, little induction of labor unless necessary. And when we define when the woman is in active labor and admit her, and how long is the first stage and how long is the second stage, because there's a practice in Jordan, some women maybe 4 or 5 hours in first stage, and they say there's a poor progress or delay in progress, or in second stage for 20 minutes or 30 minutes. So the misunderstanding of the progress and arrest of labor is an important issue in increasing the rate of cesarean section. And the last thing I think we tried in our guidelines to encourage was what you mentioned is VBAC, assisted vaginal delivery, and encourage or train residents to do breech delivery and not all breech to go for cesarean section. I think these guidelines, we published it in the year 20 and we updated it in 2023, and we hope that this will improve our cesarean section rate. It is by education, more understanding of the progress of labor, and having better trained resident doctor on assisted vaginal birth. What do you think about assisted vaginal birth, Professor Thacker? Do you still encourage, or because your fear, as I heard you this morning, forces may damage the pelvic floor muscles?
No, so I'm not saying that you should do away with forceps. I'm saying it may be the right choice. So for example, second stage, not doing difficult ones, but when you can use Wantus, you should choose Wantus over forceps. And certainly if we become proficient at assisted vaginal births, you will reduce your cesarean section rate. But what I also wanted to add is that in addition to all the things that you have suggested, I think every unit needs to have their own data and look at it on a monthly basis to see whether the cesarean section rate is going up, whether it's going down, what's happening with the emergency C-sections, what's happening with the elective C-sections, and is it primary cesarean section? And then you can actually see the trends and start questioning yourself. I think we need to start questioning ourselves.
Okay, thank you very much. Any comment?
And that was the one, in fact, you sent me your guideline at lunchtime. I've just read it very quickly, the 70 pages, but that bit was missing, to have monthly audits, annual audits, and comparing units with units within Jordan. And then you start to say, well, why are we different than the hospital, which is 6 kilometers away,
Yes, you have to answer. Okay, thank you very much. I'd like to finish my slides here with this slide, which I always would when we were having difficult or controversial subjects. Beneficence and non-maleficence are the two ethical principles in our medical practice. The physician's duty to minimize harm and to maximize benefit. Thank you very much for attending.